Hi everyone, welcome back to my channel. My name is Rahma and this is going to be our second video on endocrine. The last video we did the first part. We covered about 10 pages in about an hour, and my goal with these videos is simply to just transform the book for you in such a way that you know what you want to highlight, what is high yield based on the questions that are that can be asked on the exam. So how I usually know where these things are is because I cycle through several blocks of questions myself, and I kind of have a good idea of where all these questions are coming from, or basically this is just going to be a very quick tutoring series of videos where I tell you what you should highlight or where you need to pay attention, because this book is extremely daunting and difficult to go through, and you know, it could be better in some areas, of course. And sometimes if you're just going in solo, you're going to have a hard time with knowing every single thing, and you're going to feel overwhelmed. So this is for those of you who are just ready to take that necessary push to start reading the book, and we're going to get through this as fast as possible. So I'm going to stop talking, and then we're going to just read from where we left off. So we left off at the adrenal steroids and the congenital hyperplasias, and just a little warning in advance, since I am in my car. If you hear any noise in the background, that'll be my family, or that will be driving. So I'm going to try to read this as fast as possible and hopefully squeeze in another video for you guys here. So when you are going through the adrenal steroids section, okay, again, we're just reviewing these topics themselves. If you're going through the adrenal steroids, you don't want to feel intimidated, and this is an extremely simple area of endocrine. If you just understand the basics, which is everything starts off with cholesterol, sorry. So you start off with cholesterol, okay? Don't overwhelm yourself with such a huge looking diagram where you're going to feel like, oh, do I need to memorize every enzyme? Do I need to memorize every single thing here? No, you don't. Just understand, you have your cortisol. That is the stepping stone, that is your foundation for making your glucocorticoids, for making your aldosterone, for making your adrenal androgens. So cholesterol is your big guy over here. Now, whatever the heck happens with cholesterol, we don't really need to be too concerned with anything. We just need to know now the areas. So you have, remember from the previous video, I told you you need to know the different zones. So you have your zona glomerulosa, the zona fasciculata, and your zona reticularis. So it has your mineral corticoids, so your salt, so that's going to be your aldosterone. You have your sugar, which is your cortisone, and you have your sex. So that's one way to memorize it: salt, sugar, and sex. And they have a a way to memorize it. The deeper you go, the sweeter it gets. So salt, sugar, and sex. And here would be your adrenal androgens. So how we want to look at this chart to make it as simple as possible? Well, everything is going to start off with cortisol, and every precursor comes from the previous area, okay? You need to understand this. So in order for me to make, let's start from the very end, the zona reticularis, if you want to make that testosterone, if you want to make her estradiol, well, I'm going to have a compound that comes from the previous area, which is zona fasciculata, which is also going to need another compound which comes from the previous area, which is the zona glomerulosa. That means that it should be very easy for you to understand the different pathologies, because if I have a defect in one area, say here, well, then I won't have whatever is being produced here or here, and I'm going to have an increase in whatever is being produced here. Likewise, if I erase this line and say I have a defect going this way, well, I'm going to have the precursors for here, but nothing's going to continue down this way. I'm going to have the precursors for here, but nothing's going to continue down this way. So everything is going to shunt in this direction. So I will have increase in the adrenal androgens, for example. So that is the way to understand what is going on, and for me to explain it to you in the simplest way possible. So save yourself a lot of time and energy. Just know everything starts with cortisol and understand the way things shunt in which direction. Okay, so we're going to start off with these congenital adrenal hyperplasias, and just as the name implies, the adrenals are going to have hyperplasia because something is being increased and the amount of secretions are happening, and this is the result of the hyperplasia. Okay, so we're going to go through each of these enzymes, and you're going to see just how simple it is to understand what's going on. So for our simplicity's sake, we're going to go with the most important one, the most common one that you might be asked questions on, and the most common one you would find clinically, and that is 21 hydroxylase. Now, without looking at this chart, we're going to break down and see what is going to happen. So 21 hydroxylation happens here on the step B. So let's just do what I did and just cross out this whole section out of your mind. And you're going to understand very quickly now what this is going to look like with regards to blood pressure, with regards to cortisol levels, with regards to adrenal androgens. So I have my cholesterol up here, and I'm going down here and I'm making pregnenolone, and I'm going down here and I'm making progesterone. But now I have a block. So let's shunt both of these guys using 17-alpha hydroxylase to make 17-hydrox. So I closed off my mineralocorticoids. If this is blocked, I'm not going to have aldosterone. My blood pressure is going to be low, right? Aldosterone goes to make your blood pressure. It absorbs sodium, absorbs water. So it's going to increase your plasma volume. You're going to increase your blood pressure. That's not happening. My blood pressure is going to be low. Now your adrenals are going to be like, okay, well, I have all these precursors. What do I do with them? Go 17-alpha hydroxylase, and let's move on down to the next section. Remember, everything's moving down in this direction. Let me just make that a bit more diagonal. Everything is moving down deeper into the adrenals, so that we can remember the deeper it goes, the sweeter it gets. So we can't make salt. We can't make aldosterone. We cannot increase our blood pressure. Blood pressure is going to be low in a patient with 21 beta hydroxylase deficiency. Now we go and we make our 17-hydroxypregnenolone. You don't need to memorize any of these. We're going to go make these precursors. After review 17-alpha hydroxylase. And then we come down here to make our cortisol. We have a block. 21 hydroxylation is not available for me. Well then, now I don't have cortisol. So cortisol is going to be decreased. So what do we do with 21 beta hydroxylation? What is this guy going to look like? Well, all these precursors now are all going to shunt into adrenal androgens. So I'm going to make a huge amount of testosterone and a huge amount of estradiol if I need to convert that peripherally. So you're going to get a patient that has decreased blood pressure because it's decreased aldosterone. You're going to have decreased cortisol, and you're going to have increased adrenal androgens. Now, if you are developing as a fetus, and this is going on because this is a congenital condition, don't forget that, right? You can imagine that if you're a boy and a baby boy, I mean, both of them have ambiguous genitalia anyway, you won't really have an issue with the male child because androgenization of the genitalia is going to look male. The issue comes down to the female that is born with this condition. She will have an enlarged clitoris, and the labia will be enlarged as well, so you're going to have a virilization of the female genitalia. So let's see if we answer this correctly without needing to memorize arrows, ups and downs. There's no need to memorize anything here. 21 hydroxylase, we said we are not making our aldosterone. So our mineralocorticoids are going to be low, and our blood pressure is going to be low. You want to understand what's going on with potassium by simply understanding what does aldosterone do. Now, aldosterone is going to cause the excretion in this direction here and in this direction here. Let me just make sure I don't want to make a mistake here. So we have potassium is going to be high. So normally aldosterone, what it does, it absorbs hydrogen this way, and it gets rid of potassium into the urine. So if I don't have aldosterone to pull in H, to pull in water, to pull in the plasma volume from the urine, and to secrete the potassium, I'm going to have, as a result, decreased blood pressure. Sorry, I can't really type that well because I'm using my mouse pad. And you're going to have increased potassium because I'm not getting rid of that in the urine. Okay, so you have your increased potassium, and your blood pressure is going to fall. We said we're also going to move on to the next zone, and you're going to try to make cortisol, and you are not able to make cortisol. So your cortisol is going to be decreased. Now you have your sex hormones, which are going to be elevated. Because all the precursors are being made, they aren't able to proceed downwards, so they go down to the right-hand side, or left or deeper into the adrenal medulla. But for the sake of this diagram, it's going to be on the right-hand side. So now what happens with the labs? So you don't want to confuse yourself with the labs here. If I have low blood pressure, the renin-angiotensin system is going to try to be activated, right? That is the trigger for our VAS system. So if my BP is low, it's natural that my renin activity should be high. And then if you remember, I keep telling you all these precursors are being shunted to the right by 17-alpha hydroxylase. So everything that's 17 in front of it, that number 17, is going to be increased. So one such a marker is going to be 17-hydroxyprogesterone. You're going to find that elevated, and you know you're dealing with 21-hydroxylase deficiency. Now, this is the most common, so this is important to know if you don't want to memorize anything else. But overall, it's very easy to understand the rest of these guys. This is the most common one. It's going to present in infancy, right? And you're going to have, in the female, like we've said, viralization. You want to be aware of that. So it's a female. It looks like a baby boy, but you're not sure. Okay, something's off. Then you do your chromosomal analysis, and you see it's XX. It's female. It looks like she's having an enlarged clitoris, which you might mistake for a penis. Then you're going to say that you're going to test for the enzymes, and you're going to likely find 21-hydroxylase deficiency is the problem. Now I'm going to erase all of this, and we're going to go through the next type of enzyme deficiency. And let's use a different color so nobody gets confused. 17-alpha hydroxylase deficiency. Again, without looking at the chart, we're going to understand what's going on here. So 17-hydroxylase deficiency is over here. Okay? So we made our cholesterol. Good. We made our pregnenolone. Good. We made our progesterone. Good. We don't have a deficiency here or here, so everything's going to progress down, and we're going to make our aldosterone. So our blood pressure is going to be good. It's going to be maintained. However, when I come to make our cortisol and our adrenal androgens, I have a huge problem here because I need these precursors to go through, and 17-alpha hydroxylase is what's needed for me to make the precursors needed for the other hormones that I need. So I will not have cortisol, and I will not have adrenal androgens. I will have elevated blood pressure. Now remember the 21-alpha hydroxylase, we said you have low blood pressure. Because you have low blood pressure, you're going to activate the renin-angiotensin system, so renin's going to be high. Here I have blood pressure is going to be high, so it makes sense that renin is going to be low. Remember that aldosterone also works on potassium secretion. So if I have a lot of potassium, right, if I have a lot of aldosterone, a lot of that potassium now is going to be secreted, so I should have very low serum potassium levels. So let's check here to see if we reasoned everything correctly. Our mineralocorticoids will be elevated. Our potassium will be low. Our blood pressure will be high. Our cortisol will be low. Our sex hormones will be low. Our labs will show decreased sex hormones. In the male, you will have ambiguous genitalia. The male needs to react and respond to testosterone while it's developing so you can get that proper phenotype. If that's not happening, if it's male, you're going to get ambiguous genitalia and even undescended testes. In the female, you're going to have lacking of sexual development, secondary sexual development. Those are the development of the breasts. So we use testosterone, we convert to estrone and estradiol, which are the more potent forms of estrogen here, by aromatase in the peripheral tissue. So that is one pathway for us to obtain estrogen and estradiol, which is responsible for those secondary sexual characteristics. Now let's erase this and go to the last one, which might be tricky. And I'll tell you something. They know you're going to study 21-hydroxylation. They know you're going to study 17, and you're probably going to skip 11-beta hydroxylase deficiency. And that's where actually you're going to get your questions. So don't be tricked by this. And again, just focus on it, and you'll understand. And you'll be able to very quickly interpret the labs or the results that you're expecting. So let's pick a different color here. Let's go with orange. And the last thing is 11-beta hydroxylation. So you might have already noticed on the chart, it looks a lot similar to 21-hydroxylase deficiency. Because 21-hydroxylase deficiency had so this guy here, we're having our block in this area. While if you recall with 21-hydroxylase deficiency, you had your block in this area. Okay? Now, you're going to say, okay, well, no, this is tricky. Of course, this is tricky because this is where they're going to ask you a question. Okay, so they look the same. So remember, with 21-hydroxylase deficiency, we were not able to make aldosterone. We were not able to make cortisol, but we were able to make adrenal androgens. So it makes sense that I should have something very similar in 11-beta hydroxylation. So what's the difference? Well, I'm not able to make aldosterone with 11-beta hydroxylase deficiency. I'm not able to make aldosterone. and I'm not able to make cortisol. And everything is going to be shunted to make adrenal androgens. So adrenal androgens are going to be high with 11 beta hydroxylation, and cortisol is going to be low with 11 beta hydroxylase deficiency. But when it comes to the aldosterone being deficient, yes, aldosterone will be deficient. However, my blood pressure is going to be high. And the reason for that is because we have functioning 21 beta hydroxylase in someone who has 11 beta hydroxylase deficiency. And they are able to make 11-deoxycorticosterone. And 11-deoxycorticosterone has slight mineralocorticoid activity. That is enough for me to keep my blood pressure up. So unlike 21 hydroxylase deficiency, where my blood pressure was low because I'm not making any mineralocorticoid, I'm able to make a mineralocorticoid with slight activity. That is the 11-deoxycorticosterone. So blood pressure is actually going to be high with someone who has 11 beta hydroxylase deficiency. Now let's take a look here. 11 beta hydroxylase deficiency, aldosterone is going to be low, but 11-deoxycorticosterone is high, so it results in elevated blood pressure. You have your elevated blood pressure. Likewise, you have your slight mineralocorticoid activity, so your potassium should be low, your cortisol is low, and now you have your adrenal androgens is still high. Likewise, because you have your increased blood pressure, your renin activity is also going to be low. It presents in infancy as severe hypertension. That's important. And in the females as well, just as in 21 hydroxylase deficiency, you're also going to have the viralization. So that is the congenital adrenal hyperplasias. It's very easy, very simple to understand, and hopefully it's not too confusing and not very daunting. Excuse me. Next we have our cortisol. Now cortisol is super duper important. I'm only going to highlight for you the buzzwords that you need to know for the exam questions. Where is it made? In the zona fasciculata. Now, one way to imagine what cortisol does is simply to know that this is the guy that you need to survive, to be alive, and to basically survive any stress. And by stress we mean exams, or surgery, or infection, or severe trauma. And I'm joking about the exams, but I'm pretty sure our cortisol levels are really high during exams anyway. So you need that guy. So imagine you want to survive, right? You are under stress. You are, in trauma. You've undergone surgery. So you want to heal. You want to do all these things. Blood pressure should be high. You want appetite that should be high. You want a lot of blood sugar inside of your system. So all of these things make sense as functions of cortisol. So you don't need to think much about it. You don't need to highlight or sit down and memorize the nitty-gritty. It makes sense that you would increase your appetite. Most important though, however, you do want to, don't ever make mistakes here with these areas here, is to, that you want your blood pressure is going to be elevated. And does that by upregulating alpha-1 receptors on the arterioles. It increases the sensitivity to norepinephrine and epinephrine. You will get asked a question about this called permissive action. At high concentrations, it can also bind to aldosterone receptors and activating them. We just discussed aldosterone. He's going to increase our blood pressure and get rid of potassium. So you're going to have, at high concentrations, cortisol will increase blood pressure by doing that. Then you have increase your insulin resistance to diabetogenic, right? Think you're under stress. You just had surgery. You just had a trauma. You want to make sure that you have blood sugar that's ready and available for utilization. So insulin resistance, diabetogenic, increase your gluconeogenesis. Make that glucose from anything. Break down your fats, lipolysis. Break down your proteins to make that glucose. And then you have some key features here about cortisol, which are very important and for you to understand later, because in some pathologies we have increased inflammation, and cortisol is notorious for decreasing inflammation. So it makes sense that in those pathologies I would use cortisol. And how does that work? Well, we have an increased inflammatory and immune response. This is the basis of why it's used for such a wide variety of treatments. And then you have inflammatory and immune response. How does it work? I will tell you the most important things you might get asked. Neutrophilia and eosinopenia and lymphopenia. Okay, so what's going on here? The cortisol, it does a couple of things. Cortisol is going to decrease everything. Increase all your immune cells, increase the production of interleukins, and decrease all the productions of any of the things that cause inflammation. But it does something a little bit wonky when it comes to the white blood cells. So you have your eosinophils, you have all those cells are going to be decreased. But with neutrophils, it does something a little bit wacky, and you might get asked a question about this. So with all of the cells, it's going to sequester them in the bone marrow. So it's going to keep them there. Remember, all of your white blood cells, all these things are in the bone marrow, and then they get released, right? So cortisol is going to sequester them in the bone marrow, keep them there. But with neutrophils, it does something where it keeps them in the blood, but it prevents them from going to the area of inflammation. Now remember, when you have inflammation, right? Let's say you have a site of inflammation over here. Well, you have your neutrophils. Yeah, this is a neutrophil going through a blood cell. Well, remember, inflammation involved, like, sticking to the endothelium and extravasating through and then going through and going to the site of inflammation, correct? So what cortisol does is it prevents this stickiness from happening, this adhesion of neutrophils. So you're going to have a lot of neutrophils in the blood. They're just not able to go to the site of inflammation. And this is how you explain the neutrophilia. You're going to have increased neutrophils, decrease everything else, increase neutrophils, but they are not able to go to the area of inflammation and be utilized. So it inhibits white blood cell adhesion. That is what's most important. You're going to get neutrophilia, but with everything else, you're going to have decreased lymphopenia and eosinopenia. Next is going to be decrease your bone formation and decrease your osteoblast activity. That's important. When you give patients cortisol, you're going to have to worry about something called osteoporosis because of that. It breaks down the bones, prevents the bone formation, decreasing the osteoblast activity. The other thing is going to be fibroblast activity. It's going to decrease that. So this is really going to affect your skin. Hi, I'm going shopping. Sorry, my family's going shopping and I'm here studying with you guys. So let's get back on track. All right, so you have your, let me just regain my focus again. So you have decreased fibroblast activity. You have your poor wound healing, your decreased collagen synthesis. Remember, in somebody who has Cushing's, in Cushing's you have a lot of cortisol, and one of the key features is this stria that builds up on the abdomen, and hopefully I can find a picture here. So stria of Cushing's, because it's so distinct. Remember, don't always rely on words. It will help you to remember pictures, right? So you can get asked, and they can very easily pick up a picture of the stria that you see in Cushing's, and they'll tell you, okay, they'll give you a clinical vignette, and you'll be so happy, and you're like, oh wow, this Cushing's is so easy, and then they'll ask you, well, what is the basis of the stria that they're seeing on their abdomen? You want to know it's because it decreases fibroblast formation, and that causes weakening of the skin, so it gets really thin. Here, these are the stria that you see. So the skin, this is a very distinct picture, and I think it's commonly used in the clinical vignettes. Is you're going to see this picture, and what's happening here, right? What are these? Well, really, it's just thinning of the skin, and because it gets really thin, you can start to see the blood vessels underneath, so that's what's giving it this coloration. So that's the stria for you, and the reason for that, as we said, is your decreased fibroblast activity. You can have poor wound healing. You might get asked this in another type of way. They can tell you, well, you have a patient, they have a chronic disease like systemic lupus, or for whatever reason they're taking cortisol, right? And then they'll tell you, oh, and then they got injured, and you assess the scar, and it's not healing that well. Such a stretch, such a leap, all of these steps, just so that you know that poor wound healing occurs if you gave a patient cortisol. So that's something that you need to be aware of as possible questions. Now, another important thing is exogenous corticoids can cause reactivation of TB and candidiasis. One of the things that cortisol blocks the secretion or production of is interleukin-2. And it's very important because it helps in that formation, interleukin-2, in making granulomas, if you remember. And granulomas are the foundation of many types of pathologies, namely tuberculosis. So if that's not happening, remember that granuloma is kind of protecting your body, right? You're going to have this inflammation that's actually keeping that microbe in that area. And if you're decreasing or blocking your interleukin-2, you're going to affect this, and then you're going to have reactivation of tuberculosis or candidiasis or other types of latent type of infections. So that's something to keep in mind. Next is your appetite regulation. I don't think this is something you really need to go through because I've never seen questions on it other than remembering that GER GERD, like your stomach is growling. Ghrelin makes you hungry, so that's what stimulates your appetite. So leptin is your satiety hormone, on the other hand, so that's what makes you full. And this appears to be something new, and I have seen one question on it, is endocannabinoids. So endocannabinoids, so we have our own cannabis production in our body, and we have cannabinoid receptors, and we can use cannabis if they will ask you a question about its potential uses. And it's going to work by activating the hypothalamus and nucleus accumbens, and it actually is going to make you hungry, right? So you're going to have loss of hedonic control of food intake. You're going to increase your appetite. People who smoke weed or use marijuana, they have a condition, or they know they have the munchies. They like to smoke and they like to snack at the same time. The reason for that is because endocannabinoids are triggering hypothalamus and nucleus accumbens, and you start to eat. So you'll ask your question like, well, what can I use this for in a medical setting, right? So you want to say, well, somebody who has anorexia related to cancer, right, or cachexia related to cancer, they don't have an appetite, so I can give them endocannabinoids to stimulate their appetite. Another example, I believe, is chemotherapy related as well. So chemotherapy and cancer-related cachexia are two conditions where I can use endocannabinoids. And in general, and I think I'm just saying this because I'm working on a paper right now regarding endocannabinoids. In general, it's also used for seizures, mostly, yes, so seizures and any situation where you want to increase the appetite. So that's it for endocannabinoids. Now, here we come to the part that I personally despise with a passion, which is the signaling pathways of endocrine hormones. You will get asked a million possible questions on this. There is no way out of it other than to memorize it, unfortunately. And I don't like areas where that's the only resort that you might have. They will ask you any one of these hormones, and they'll tell you, well, what is the signaling pathway for it? And it can seem daunting to memorize all of this. I mean, for me, I am aware that there are some that they like to ask more about. So those are going to be the non-tyrosine receptor kinase, and namely erythropoietin. You need to be aware of that. So any of these guys, it's worth remembering that they use the non-receptor tyrosine kinase. And there isn't really much for me to explain. This is just something that you have to memorize, one of those unfortunate tables. So GCDSF, you have your erythropoietin, which also uses the non-receptor tyrosine kinase, and thrombopoietin. So what does this mean? At least for this one, this is maybe something I can explain. For this one here, you might think of something like polycythemia, and if they'll ask you, well, what's going on here, it would be using a non-receptor tyrosine kinase. That could be a question. I have not seen as far as the receptor tyrosine kinase, well, we know insulin works using the receptor tyrosine kinase. I feel like I'm studying with you guys here. I really hate this table. But I mean, it's the most concise way, and there's definitely a lot of questions that you can get asked here. So receptor tyrosine kinase is anything that has a GF. So they break it down for you, I guess, in a simpler way to memorize it. You want to know your intracellular receptors. Which ones work on intracellular receptors? You have your progesterone, estrogen, testosterone, cortisol, aldosterone, T3, T4, and vitamin D. Those guys are pretty like the big guys when we think of hormones, right? Your progesterone, estrogen, testosterone, your cortisol, your aldosterone, your thyroid hormone, your vitamin D. So those are the big guys. Those are the ones that work intracellularly. So those are worthwhile to memorize. You have also your non-receptor tyrosine kinase. You might get asked IP3. There's no limit to what you can be asked here in this section. So I am going to move on, and that's up to you guys to sit down and memorize it. Just pen and paper and doing questions. But as far as questions are concerned, the ones that I have personally seen a lot of things on are intracellular receptors and non-receptor tyrosine kinase, and maybe the CAMPs are definitely another one. Signaling pathway of steroid hormones. Again, this is also not that important. We're trying to just get through the most high yield things here. Syndrome of inappropriate antidiuretic hormone secretion. So if you watch the previous video on this topic, we have discussed something called ADH. So ADH, remember, it is formed in your posterior pituitary. In your hypothalamus it's formed, then it's stored in your posterior pituitary, and it gets from the hypothalamus to the posterior pituitary using something called neurophysin. Remember, there's a lot of questions that can come through this. So antidiuretic hormone, so think of the word and what it means. Antidiuresis. So I don't want to pee a lot. Keep things as simple as possible. We don't want to pee a lot, so what do we do? So here is our tubule, right? And it has all of this urine in it. and I don't want to pee a lot. So let's just change the color here to make things simple. So what can we do? Let's just say this is a tubule full of urine. Well, ADH is going to do something called insertion of aquaporin 2 channels here. Okay, and this is going to absorb all of that fluid and bring it back into the plasma. Okay, so this is how we have our antidiuresis, right? You're not peeing, antidiuresis. Now the urine, I've pulled out all the water from it, so that water goes to the plasma. Then what ends up happening is the urine becomes concentrated, right? So if I take out water from something, it's going to have more solutes. That solutes is going to make up the osmolality. So osmolality of urine will go up when you have ADH. Now we have a lot of conditions involving ADH, and it can be confusing, but if you have your foundations, it will make sense. So just a second, let me just fix this because my battery is dying. Oh no, we have 20 minutes left together. Let's do syndrome of inappropriate antiderivative hormone secretion. So what is it characterized by? It is characterized by excessive free water retention, which we've just explained how that happens, and euvolemic hyponatremia with continued urinary sodium excretion. So with this going on, you would think that, wow, I'm filling up the plasma with a lot of volume. But incidentally, what also happens, because this increase in volume is going to be sensed by the heart, and the heart is going to secrete ANP and BNP, and these guys cause natriuresis, which is get sodium out of here. So if you get sodium out of here, we do know one thing when it comes to sodium. Wherever sodium goes, water follows. So the sodium goes here, and with it, you're also going to get water. So you're going to have euvolemia and hyponatremia. That is how you understand ADH and what it does. So you have euvolemic hyponatremia with continued sodium excretion. At the end of the day, now that I'm putting sodium into the urine after I've already pulled out water from it, it's going to be even more concentrated. So urine osmolality is going to be extremely high in these patients. The body responds to the water retention from the ADH. Remember, ADH put the aquaporin channels, absorbed all that water, and now I have water retention. How do I respond? By increasing ANP and BNP, as well as decreasing aldosterone. The urinary sodium secretion is going to increase. You're going to get normalization of the extracellular fluid volume. You're going to have euvolemia. But because I got rid of sodium, I'm going to have hyponatremia. Very low sodium levels can lead to problems. Cerebral edema, seizures. Correct slowly to prevent osmotic demyelination syndrome, formerly called cerebellar pontine myelinosis, and this is something we can discuss in greater detail with nervous system, which will be the next system that I will do after we finish endocrine. So SIADH is held up water. So what are the causes? Well, frequently the cause is going to be head trauma and CNS disorders. Do not underestimate how many times they will ask you this question. A lot of the times it's just like somebody came out of a motor vehicle accident and they're not peeing as much. And one of the reasons can be SIADH, syndrome of inappropriate antiderivative hormone. Or you will have ectopic ADH. So these two are really, really important. Head trauma, CNS disorders, I don't know why, but for some reason, for me personally, I'm not always clicking head trauma with SIADH. So a lot of times I just get another case and I think, okay, well, some other CNS cause is resulting in this. But it is SIADH, so it could take some time to get used to. So don't forget that, please. Head trauma, CNS disorders, tumors, then a previous surgery on the brain, and now they're having these symptoms, then that's SIADH. Ectopic ADH is another issue. Sometimes, and especially notorious, is small cell lung cancer. Small cell lung cancer is notorious for something called paraneoplastic syndrome. Paraneoplastic, as the name implies, paraneoplastic beside the tumor. Beside the tumor, I have another set of syndromes that I'm dealing with, and that's usually because of two things. Either the tumor is secreting hormones, or the body is having an immune reaction to the tumor cells, and that's causing another syndrome. So with regards to ADH, some tumors are going to be secreting ADH, and that's namely small cell lung cancer. It's also going to secrete a whole bunch of things, antibodies, for example, against the postsynaptic calcium channels, so you're going to get Lambert-Eaton syndrome. So with paraneoplastic syndrome, you either have an immune issue or you have a hormone issue. So one such hormone is going to be ectopic ADH, and that can be a cause of SIADH. Another thing worth your while as well, they will ask, and it can come up as a psych question or otherwise, is that some drugs like SSRIs and carbamazepine, these drugs can cause SI, ADH. So that's worth your while to be aware of. I don't think I'm going to have enough time to continue. Actually, let's just try and push through so that I don't have to start the next video with antidiuretic hormone. Next, you have something called primary polydipsin diabetes insipidus. So now we're talking about the exact opposite problem here. So with diabetes insipidus, you need to be aware that the word diabetes is a misnomer. A misnomer means something that I named incorrectly. Because we are used to knowing a condition where somebody is peeing a lot, polyuria, as diabetes. So you got this person who's peeing a lot, and you're like, okay, is it diabetes? You check their urine. Urine in someone diabetic is going to be sweet. It's going to have glucose. That's technically how they figured this out long, long ago. Some dogs who had diabetes, whenever they would pee on the ground, they noticed that ants were very attracted to this area. That's what got them to test the sugar. That's what got them to test the urine, and they found out that there was sugar. So diabetes has sugar in their urine, and we know that sugar has osmotic pull. It has this dragging effect. So if it's there, it's going to pull water with it. So that's why you have polyuria. But when we test this patient who has diabetes insipidus, well, the urine is a lot, and the osmolality is low. So what happened here is that it's insipid. Insipid means a lot. So it's diabetes insipidus, but it's not diabetes. It's nothing to do with blood sugar levels here. So we have central diabetes insipidus, and we have nephrogenic diabetes insipidus. So what's going on here? Well, either I am producing ADH. So I have ADH molecule here, right? We've already discussed how it functions through putting in the aquaporin channels, and then you make the urine more concentrated, correct? Now, I have diabetes insipidus. Either I am not making ADH. Remember, it's made in the hypothalamus and stored in the pituitary, posterior pituitary. Or when I'm secreting it, but my kidneys are not responding to it due to a mutation of the receptors. So what is this going to look like to me clinically, and how do I figure this out? Well, central diabetes insipidus is decreased ADH release. I'm going to highlight this stuff in red for you. Central diabetes, we just said, is decreased ADH release. Nephrogenic is ADH resistant. The kidney is the problem. The kidney is the one that's resisting ADH, likely due to a mutation, and it's not responding. What are the causes of central? Well, central causes idiopathic or brain tumors, especially pituitary tumors, infiltrative diseases like sarcoidosis, trauma, surgery, hypoxic encephalopathy. All these causes are important to know. Nephrogenic, we said, is a hereditary mutation. But another important cause of nephrogenic, and again, this can be another link to psych, is lithium. If you have a patient who has bipolar disorder and you give them lithium and they start complaining, well, what would they complain of, right? What is the complaint here with diabetes insipidus? Well, if I am not able to pull water out from the urine, I'm going to be peeing a lot. The patient becomes conscious of one thing, that they are peeing more than they are drinking. That is a complaint that's going to end up at your office. They're going to say, doctor, I am not drinking enough water to validate how much I'm using the bathroom. So, one such cause is lithium. So, if someone who has bipolar disorder, and again, you can be asked, bipolar, and they'll tell you, oh, this person complains of depressive symptoms for 2 weeks, and then they have symptoms of hyperactivity and lack of sleep and talking a lot and jumping from thought to thought, and then you're like, okay, great, this is a psych question. They'll tell you, oh, and by the way, there's something off with their urine osmolality. What are you going to do? It's probably drug-related effect. So, that's likely it's coming out of the lithium that you probably gave them. So that's important to keep in mind. So that's one way to question that. So put a little star beside that. So let's understand, and we'll get to polydipsia later. But let's understand what's going on with serum osmolality. Well, serum osmolality is going to be elevated. And your ADH level here is really the biggest clue sometimes. So your ADH level definitely is going to be decreased in central because I'm not making it. So we can test two things to figure out, am I dealing with central or am I dealing with nephrogenic? Well, if I do water restriction, what is going to happen? Okay? And this is when I'm going to discuss polydipsia. Primary polydipsia is a psychiatric illness. The person drinks water. Now don't forget, the number way to cause diuresis is to drink water. Water, and we call that osmotic diuresis. So drinking water is going to make you use the bathroom. So both of them are going to look the same, with the diabetes insipidus, central or nephrogenic, and polydipsia. So I'm going to do something to rule out polydipsia versus diabetes insipidus. And I'm going to tell this person, restrict your water. Don't give them any water. Now, if I don't give you water to the person who's been drinking water, causing osmotic diuresis, and then I test their urine, well, I'm going to find out that it starts to get concentrated. So I'm going to find increased urine osmolality in a person where I do water restriction. Then I know that the cause was polydipsia. Let's repeat that again. The patient who's taking water causing osmotic diuresis, if I prevent them from drinking water, well, then they're going to start to concentrate their urine. Because now ADH goes in and it does its function normally, not at the level where it's being overwhelmed by the osmotic water that I keep drinking. So you're going to concentrate your urine in the case of water restriction, and that's the end of the story for polydipsia. Now, when we come to diabetes and insipidus, either of the causes, I'm going to have no change with water restriction. Water restriction or not, I'm losing water in the urine. I'm losing volumes in the urine. So if I check the osmolality, it's still going to be high. It's still going to be low because the urine is very dilute. The osmolality is going to be low. This has nothing to do with drinking water. So water restriction and diabetes insipidus, you're going to have no change. And that no change is because the kidney's either not responding to ADH or you're not making ADH. You're not able to concentrate the urine. So now what do I do to figure out between central and nephrogenic? Well, I'm going to give an analog of ADH. Remember, ADH also has another name called vasopressin, which works directly to increase the blood pressure. So I will give desmopressin administration. And I'm going to check the urine osmolality. Now, without looking at the chart, if I have central diabetes insipidus, which is caused by decreased production of ADH, and then I give this patient ADH analog called desmopressin, the osmolality is going to increase of the urine because I just gave them the thing that they don't have, which is ADH. ADH is going to go and put in the aquaporin channels. It's going to pull that water out from the urine, put it in the plasma, and now the urine is going to be concentrated. So if I have more than 50% increase in urine osmolality after desmopressin administration, I know I'm dealing with central. Now what's going to happen with nephrogenic without looking? I have a patient who has nephrogenic diabetes insipidus. I stop them from drinking water. No change. Now I give them desmopressin analog. To someone who has mutated receptors and there's resistance in the kidney to ADH, nothing's going to happen. The osmolality of the urine is going to remain low in this patient. They're still not able to concentrate the urine. So it doesn't matter if I give them desmopressin administration. They are not able to respond to the desmopressin. So you're going to have minimal change in urine osmolality. But with the central one, you're going to have significant increase in osmolality because I wasn't making any. More than 50%. So treatment makes sense that for the central, we will have desmopressin as therapy. For the water restriction, for the primary polydipsia, and for the patient who has the nephrogenic one, well, I need to find another way to get rid of this, to concentrate everything. So you want to have a low solute diet. And let me just erase this. Okay. So you want to manage underlying cause, of course. And very likely the only cause you want to be dealing with, or you want to keep in mind, is lithium, if they get asked again with the BPD. If you get asked with the BPD and lithium, then stop it and switch to a different drug. Low solute diet, HCTZ, amiloride, indomethacin, for examples. Again, they will love to ask you questions. I've never seen questions really on the treatment. Mostly this section here is knowing what happens with water restriction and what happens with the osmolality at the end of the day. And I will end this video here, and I will see you guys next time. Hopefully you can get through more questions and more pages at a faster rate. I hope you've benefited, and I will see you guys in the next video.